This video presents the anatomy of the face and parotid region. Let's start at the top of the face and we'll work our way down through the muscles of facial expression. Notice that the muscles with a box around them are those that you will be identifying in lab. The muscles in gray I will not hold you responsible for, but I will briefly discuss a couple of them. All of these muscles are relatively thin, and some of these muscles of facial expression make their insertion directly into the skin of the face. So take your time dissecting and gently remove the skin from the muscle. The first muscle shown here on the left of the screen is the epicranius muscle, also known as the occipital frontalis muscle because of its two bellies. The frontalis muscle, or the frontal belly, overlies the frontal bone and it functions to wrinkle the skin of the forehead. It also raises the eyebrows. As the saying goes, nothing raises eyebrows like frontalis. The frontal belly is connected to the occipital belly through the epicranial aponeurosis, which also constitutes one of the layers of the scalp. The occipital belly, found over the occiput, will ever so slightly draw the scalp posteriorly. There are also three muscles around the ear that don't do a whole lot. From their positioning, you can assume their function. These muscles will either draw the ear forward through the anterior auricular muscle, upward through the superior auricular muscle, or backwards posteriorly through the posterior auricular muscle. Here's a quick demonstration. Gently rest your fingers on the tops of your ears with your fingertips touching your scalp. Now make a really big, obnoxious smile. To create the full effect of a smile, the superior auricular muscles slightly raise the ears, and you can feel these muscles tense on the side of your head when you make that big, obnoxious smile. These same auricular muscles are much more pronounced in animals, like dogs, for example. Hence, animals have a greater range of ear motion than we do in order to detect and locate potential predators. Now let's turn our attention to the eyes and nose. The orbicularis oculi muscle functions to close the eyelids. If the eyelids are shut forcefully, then the orbital part of this muscle is contracting, which is oriented in concentric circles around each eye. The palpebral part of this muscle, which covers the upper eyelid, is active during blinking or when gently closing the eyelids. Realize that the skin of the eyelids is about 1 to 2 millimeters thick. It is actually the thinnest skin in the body. So when we remove the skin of the face, we will leave the skin on the eyelids intact. Lying on the dorsum of the nose is the nasalis muscle, as shown here. This muscle is anchored to the nasal bone and it reaches downward to the nares. The nasalis flares the nostrils to take in a deep breath of air through the nose, for example. And the depressor septi will assist in widening the nares. Here's the very small, insignificant depressor septi. Because the mouth and lips are highly mobile, it makes sense that the majority of the muscles are concentrated in this region. The levator labii superioris aliqui nasi is the longest named muscle in the body. It's nicknamed the Elvis muscle. When this muscle contracts, it assists in flaring the nostrils, and it simultaneously will help to raise the upper lip. As you may recall, this was one of Elvis's signature facial expressions. For many of the muscles shown on this slide, the function of the muscle is depicted in its name. For example, levator labii superioris, here, refers to the fact that part of this muscle is raising the upper lip. Levator means to elevate, labii referring to lip, superioris gives the direction. The latter part of the name of this muscle, aliqui nasi, refers to winging, which is what aliqui means, of the nose, referring to nasi. Shown here just lateral to the levator labii superioris aliquinasi is the levator labii superioris, shown here. Again, as its name suggests, it's going to elevate the upper lip. And it will also help to deepen the nasolabial sulcus. Notice how many of the fibers of these muscles which reach down toward the lips blend with the circular orbicularis oris muscle. The zygomaticus major and minor muscles originate from the zygomatic bone, which is the cheekbone, and their fibers also insert and blend with the orbicularis oris fibers around the mouth. The zygomaticus major muscle is responsible for raising the corners of the mouth, and it helps to move the lips laterally to make a smile as well. The depressor anguli oris muscle originates from the mandible, and its fibers blend with the orbicularis oris fibers. When this muscle is activated, it will depress the corners of the mouth, helping to generate a frown. The depressor labii inferioris muscle, as its name suggests, will depress the lower lip. This is important for conveying the emotion of sadness. The mentalis muscle overlies the chin. It is responsible for both raising and protruding the lower lip. Due to its action, it is colloquially known as the pouting muscle. The fibers of the orbicularis oris muscle completely encircle the mouth, as shown here. These fibers are responsible for pursing the lips in order to accomplish whistling and kissing, for example. The fibers of the orbicularis oris muscle also help to keep the lips closed in order to resist distension while eating and drinking. Now let's turn our attention to the deep muscles of the face, the first of which is the buccinator muscle, shown here. The buccinator muscle originates from the pterygomandibular raphe, and it too inserts and blends with the muscle of the orbicularis oris. You're going to find the buccinator muscle just deep to the buccal fat pad. Here on the left of the screen is where the buccal fat pad lies. Once you excavate the fat from this area, you'll finally be able to visualize the buccinator muscle lying deep to that fat pad. The buccinator forms the muscular component of the cheek. When it contracts, it presses the cheek against the teeth to keep food out of the oral vestibule, which is the area between the teeth and the cheek. The buccinator muscle also assists in the forceful expulsion of air from the oral cavity, and it resists distension when blowing. Imagine yourself blowing up a non-compliant balloon. To prevent your cheeks from puffing out like a chickmunk, the buccinator muscle contracts, thereby resisting distension of the cheeks while blowing forcefully. The levator anguli oris muscle lies just deep to the zygomaticus muscles, and as its name suggests, it will be responsible for elevating the corners of the mouth. This muscle is important for producing a smile. And lastly, I'll just mention the risorius muscle. This muscle will be responsible for helping to produce a grin by pulling the corners of the mouth laterally and slightly upward. This particular muscle can be tough to find in dissection, so don't worry about it. All of the muscles of facial expression which we just covered are innervated by the facial nerve, cranial nerve number 7. The facial nerve exits the base of the skull at the stylomastoid foramen, which is a small opening situated between the very pointy styloid process and that bump behind your ear which is palpable, called the mastoid process. Immediately after the facial nerve exits the skull, it sends off two small branches to innervate both the posterior belly of the digastric muscle, as shown here, as well as the stylohyoid muscle, which is not shown in this image. Let me remind you that embryologically, the posterior belly of the digastric muscle, along with the stylohyoid muscle, and all of the muscles of facial expression, are derived from the second pharyngeal arch. As such, all of these muscles have the same innervation through the facial nerve. After innervating two of the suprahyoid muscles, the facial nerve then courses through the contents of the parotid gland as it enters onto the face. And within the contents of the parotid gland is where its 5 terminal branches originate. The names of the 5 terminal branches can be remembered by the saying, "The zebra bit my cheek." The refers to the temporal branch of the facial nerve, which will head up at an oblique angle toward the orbicularis oculi and toward the frontalis muscle. The zygomatic branch, shown here in purple, will cross the zygomatic bone and will supply those muscles which are responsible for raising the corners of the mouth and the upper lip. The buccal branch, shown here in yellow, will cut horizontally across the face to innervate the muscles near the cheek, for example the buccinator muscle and the risorius muscle. The marginal mandibular branch courses over top of the mandible and innervates those muscles that will depress the angle of the mouth and the lower lip. And lastly, the cervical branch, shown here in green, is mostly responsible for innervating the platysma muscle. Here's a brief word of caution before moving on. Be careful not to confuse V3, the mandibular nerve, with the marginal mandibular nerve. These nerves are separate and distinct from one another. The marginal mandibular nerve again is a branch of 7, whereas V3 represents a branch of the trigeminal nerve, cranial nerve number 5. In addition, V3 is a mixed nerve, meaning that it carries both motor and sensory information, whereas the marginal mandibular nerve from 7 is only motor. And if that's not confusing enough, the buccal branch of 7, which is purely motor, should not be confused with the buccal nerve, which is a branch of V3. The buccal nerve branching from the mandibular nerve V3 is largely sensory to the skin and the mucosa of the cheek, whereas again the buccal branch from 7 is purely motor. Bell's palsy is an umbrella term which generically describes unilateral paralysis of facial muscles. Every year, Bell's palsy affects about 30,000 to 40,000 people in the United States alone. Facial paralysis is most commonly caused by the herpes zoster virus. This virus tends to cause a nerve lesion in the area of the stylomastoid foramen. Trauma, such as a skin laceration to the face, can also cause Bell's palsy. Not only does drooping of muscles on one side of the face occur in this condition, but patients often find it very hard to drink and eat. This is because the contents of the oral cavity fall out of their mouth. Without the orbicularis oris and the other muscles around the mouth being innervated, the tone of the mouth is lost. Therefore, it can become very difficult for patients to keep contents within their mouth while they're chewing or drinking. Another sign or symptom involved with Bell's palsy is crocodile tears. Notice this patient in the lower right of the screen. This patient has been asked to produce a smile. Here you see a normal right side of his face where he's able to raise the corner of his right mouth, but on the left side is where he has Bell's palsy. Not only can he not raise the corner of his left mouth, but notice his eyelid, his lower eyelid in particular, is further away from his eye than normal. As a result, the tears that collect on the surface of his eyeball are unable to be drained via the nasolacrimal duct. As such, they well up and spill over onto the cheeks. That's a condition referred to as crocodile tears. If you ask this patient to blink his left eye, he would likely be unable to do that as well. As a result, Bell's palsy patients often have red, irritated eyes because they're not able to wash the tears across the surface of their cornea via blinking. Bell's palsy patients may also experience a drier mouth than normal and even diminished taste. The signs and symptoms of Bell's palsy that a patient presents with are solely dependent upon the location of the nerve lesion. Hiding beneath the muscles of facial expression are 3 small foramina, which transmit cutaneous nerves and vessels to the face. These foramina are almost in vertical alignment with one another. These openings include the supraorbital foramen, or notch, as shown here, which is found at the upper rim of the orbit. Next is the infraorbital foramen, positioned just beneath the inferior rim of the orbit. And thirdly is the mental foramen, shown here, which is located in the chin just inferior to the first premolar tooth. Emanating from these foramina are vessels and nerves of the same name. The nerves are branches of the trigeminal nerve, which are involved in providing cutaneous innervation to the face. V1, for example, which is the ophthalmic nerve, conveys cutaneous sensations from the forehead, the upper eyelids, and the nose. In addition, it also receives sensations from the cornea, the frontal sinuses, and the nasal cavity. As you'll eventually learn, the afferent limb of the corneal blink reflex is carried through V1, the ophthalmic nerve, while the motor limb of the reflex is carried through 7, the facial nerve. V2 denotes the maxillary nerve. This nerve conveys sensory information from the cheek and upper lip, as well as the anterior temple. In addition, it also conveys sensations from the upper teeth, the nasopharynx, and the maxillary sinus. And finally, the mandibular branch of the trigeminal nerve, abbreviated V3, covers the area of skin overlying the lower jaw, the lower lip, and the posterior temporal region. Branches from this nerve will also carry sensory information from the lower teeth and the oral mucosa. Here is a more comprehensive view of the 3 divisions of the trigeminal nerve and their specific branches. Shown in green is the ophthalmic nerve, which exits the skull at the superior orbital fissure. Notice how it gives off branches to supply the skin of the forehead and the anterior scalp. As we'll learn soon, these branches are referred to as the supraorbital nerve and the supratrochlear nerve. We'll revisit these nerves in more detail in the orbit lecture. In addition, the ophthalmic nerve gives rise to the infratrochlear nerve as well as the external nasal nerve, which supplies the area on the tip of the nose. In orange is the maxillary nerve, which exits the skull at the foramen rotundum. As we said a moment ago, the maxillary nerve innervates part of the anterior temporal region. It accomplishes this through the zygomatico-temporal nerve, as shown here. And here is the infraorbital nerve, exiting through the infraorbital foramen. This again is a branch of the maxillary nerve, which will innervate the upper teeth and the area over the maxilla. The sensory branches of the mandibular nerve V3 are shown here in light blue. Notice how the auriculotemporal nerve innervates the majority of the temporal region. And here we see the long buccal nerve, not to be confused with the buccal branch of cranial nerve 7, innervating both the oral mucosa of the cheek and the skin overlying the cheek. And the last cutaneous nerve to branch from the mandibular nerve V3 is referred to as the mental nerve, which exits via the mental foramen. This nerve supplies the skin over the chin. On occasion, the normal function of facial sensory nerves can be disrupted in a condition known as trigeminal neuralgia. Trigeminal neuralgia, also known as tic douloureux, is the most common form of facial neuralgia. Pain in these patients is felt unilaterally and is often described as an electric shock, searing, or stabbing pain. Patients with this condition often feel pain in the region innervated by V2, the maxillary nerve. Pain is commonly triggered when the face is touched or when the patient brushes his or her teeth. The current theory for the etiology of this condition is that there are abnormal blood vessels that compress the nerve, making it hypersensitive. Anticonvulsive drugs are usually successful at treating this condition, but if additional measures are needed, microvascular decompression surgery can be performed. In this surgery, the vessels surrounding the nerve are either removed or repositioned. During physical examination, it is common for a clinician to palpate the lymph nodes of both the face and the neck. They usually begin with their hands behind the jaw, and they feel in a forward-moving direction, toward the chin. With this maneuver in mind, both the preauricular nodes and the parotid nodes would be the first felt by the physician. These nodes are responsible for draining the eyelids as well as part of the nose and the upper cheek. The submandibular nodes lie underneath of the mandible, and they have a role in draining the cheek, the nose, the upper lip, and parts of the lower lip, especially at the corner of the mouth. The submandibular nodes also drain the anterior tongue, the gums, and the oral mucosa. And lastly, the submental nodes are located immediately under the chin, and they are responsible for draining the lower lip and the chin bilaterally. The main arteries responsible for supplying the face include the facial artery, the maxillary artery, and the superficial temporal artery. As you might recall, these are 3 of the 8 branches which arise from the external carotid artery. As a reminder, the facial artery originates just above the lingual artery, which can be found in relationship to the tip of the greater horn of the hyoid bone. Immediately above the origin of the lingual artery is the facial artery. And don't forget that the external carotid artery terminates as both the maxillary artery, which runs deep into the infratemporal fossa, and the superficial temporal artery. The highly tortuous facial artery and the less tortuous facial vein supply and drain much of the lower face. The facial artery is a branch of the external carotid artery. It passes deep to the submandibular gland before emerging onto the surface of the mandible. As the facial artery courses towards the lips, it divides into a superior and inferior labial artery, as shown here. Here's the inferior branch, and here's the superior labial artery. Remember, the word labia refers to lips. Once the continuation of the facial artery reaches the nostrils, it undergoes yet another name change and becomes the angular artery, which runs along the side of the nose, as shown here. The supraorbital artery emerges from the supraorbital foramen, along with the supraorbital nerve. This artery is a branch of the ophthalmic artery, which supplies the upper orbit and the forehead. Again, the 2 terminal branches of the external carotid artery are the maxillary artery, shown in relief here behind the parotid gland, and the superficial temporal artery, shown here. Notice that the superficial temporal artery gives off a transverse facial artery, which makes a path along the zygomatic bone towards the zygomaticus major muscle, and it supplies the middle of the face. On occasion, this transverse facial artery might arise from the superficial temporal artery within the substance of the parotid gland. When trying to identify this artery, look for the parotid duct, shown here, and the zygomatic arch, shown here. This artery can often be found somewhere between these 2 landmarks. Branches of the maxillary artery supply the deep face. These branches arise from the maxillary artery as it courses through the infratemporal fossa. For example, the artery shown here is the inferior alveolar artery. This artery, for most of its course, runs along the inner surface of the mandible until it exits here at the mental foramen and changes names to become the mental artery. The buccal artery also originates from the maxillary artery and is responsible for supplying the buccal muscle and the area of the cheek. The infraorbital artery, as shown here, exits from the infraorbital foramen just below the lower rim of the orbit. This artery, along with the infraorbital nerve, will supply the area of the maxilla, including some of the upper teeth. The facial vein is the main vein to drain the face. The union of the facial vein with the retromandibular vein forms the common facial vein, which drains directly into the internal jugular vein. Because we have more veins than arteries, veins tend to interconnect more often. The superficial veins of the face connect to deeper pterygoid veins in the infratemporal fossa. They can also connect to ophthalmic veins that run through the orbit. Ultimately, the deep veins of the face and those of the orbit connect to the cavernous sinus, which is shown here. The cavernous sinus is a venous pool of blood on either side of the sella turcica surrounding the pituitary gland. Because there are no valves in the veins of the face, blood can flow in either direction. Therefore, infections that originate in the face can spread intracranially in the blink of an eye. No pun intended. The retromandibular vein, as shown here, begins at the joining of the superficial temporal vein with the maxillary vein. And either within or just deep to the parotid gland, the retromandibular vein divides into an anterior and posterior branch, as shown here. As per the previous slide, we just learned that the anterior division of the retromandibular vein unites with the facial vein to form the common facial vein, which drains into the internal jugular vein, labeled number 6. However, the posterior division of the retromandibular vein coalesces with the posterior auricular vein in order to form the external jugular vein, as shown here. The parotid gland is the largest of the 3 paired salivary glands, and it lies over top of the temporal mandibular joint and the ramus of the mandible. The parasympathetic fibers innervating the parotid gland for stimulation of salivation are derived from the glossopharyngeal nerve, cranial nerve number 9. We will look at this elaborate pathway in just a moment. On this image, I have drawn in a nerve which represents the auriculotemporal nerve. The auriculotemporal nerve is a branch of V3, the mandibular division of the trigeminal nerve. The auriculotemporal nerve carries sensory information from the temple and from the parotid gland itself. In addition, the auriculotemporal nerve carries parasympathetic information to the parotid gland to stimulate salivation. The parotid gland secretes saliva into the parotid duct, which is also known as Stenson's duct. This duct extends anteriorly from the gland and it pierces the buccal fat pad and the buccinator muscle in order to enter the oral cavity. Within the oral cavity, the papilla and opening of the parotid duct lie adjacent to the second maxillary molar. You can both see and feel this papilla in the oral cavity. For example, press the tip of your tongue against the superior lateral cheek, and you'll feel a small bump. Feels almost like scar tissue. This is the papilla of the parotid duct. And just for fun, have you ever blown up a balloon for a party and all of a sudden get this agonizing pain in the jaw? Well, instead of inflating the balloon, you've actually inflated the parotid duct. And what you think might be jaw pain is actually pain from the inflamed duct itself. If we look at the general morphology of the parotid gland, you'll notice that it is essentially an inverted triangle, with the base of the triangle sitting superiorly at about the level of the zygomatic arch, and its apex sits inferiorly near the angle of the mandible. If we look at this gland from above, you'll notice that it is nestled between the ramus of the mandible, shown here, and the mastoid process, shown here. And nearby the mastoid process is that pointy styloid process. And notice that from between those two structures emerges the facial nerve from the stylomastoid foramen. And as the facial nerve exits the stylomastoid foramen, it courses directly through the substance of the parotid gland and courses superficial to the retromandibular vein and the external carotid artery. It is also worth mentioning that the parotid gland is enclosed by an extension of deep cervical fascia referred to as the parotid sheath. So any swelling of the parotid gland not only compromises the gland itself, but it may also affect the structures passing through it. Mumps, for example, used to be a very common childhood disease which would cause inflammation of the parotid gland. Severe pain is associated with this condition because the parotid sheath limits the glandular swelling. Movements of the jaw are especially painful for individuals with mumps. Inflammation of the parotid gland is termed parotitis, and in extreme cases, mumps can cause facial palsy or Bell's palsy because the swelling of the gland compresses the facial nerve. For unknown reasons, mumps tends to occur bilaterally, while infections of the parotid gland tend to occur unilaterally. Pop quiz. So which nerve would sense pain generated from parotitis of the parotid gland? The answer is the auriculotemporal nerve. Fortunately, the disease of mumps is now very rare due to the availability of vaccines. Here's an MRI of the area. If you look closely, you can recognize what looks to be the retromandibular vein, as shown here, and just deep to that is the external carotid artery. Recognize that these vessels course within the substance of the parotid gland, as you should see here. In this particular image, it's demonstrating a parotid gland tumor, which in this case is more dense than the parotid tissue itself. Roughly 80% of salivary gland tumors occur in the parotid gland. Because the parotid gland is closely intertwined with the facial nerve, surgical removal of a parotid tumor is difficult and carries high risk. As a result, patients have to sign a waiver of consent, saying that they agree to the risks and acknowledge the fact that there could be facial paralysis as a result of the procedure. During a parotidectomy, the facial nerve, cranial nerve 7, has to be identified, dissected out, isolated, and preserved. Here's an image that was captured during a parotidectomy. This mass of tissue that you're seeing on the blue towel is the parotid tumor that has been resected. And notice here that the facial nerve has been spared. It is also possible to have parotid gland stones, which are known as sialoliths. These stones can develop either within the main parotid duct or within the smaller ducts leading to the parotid duct. And as you might imagine, this condition is relatively painful, especially when a patient is salivating. A simple way to test for parotid duct stones is to place a drop of lemon juice on the patient's tongue. If pain is elicited upon salivation, then stones are likely. Another approach would be to take an MRI, for example, to see if calcifications are visible within the parotid duct or within the parotid gland. Getting parasympathetic fibers to the parotid gland requires somewhat of an elaborate pathway which involves 4 named nerves. This pathway begins with the glossopharyngeal nerve, cranial nerve number 9. From the glossopharyngeal nerve, parasympathetic fibers are sent through the tympanic nerve. The tympanic nerve is a branch of the glossopharyngeal nerve, and it also carries sensory fibers from the middle ear. The tympanic nerve enters the middle ear via the tympanic canaliculus, which is indicated by this small ring illustrated here. From this perspective, we can visualize the tympanic nerve as it enters into the middle ear cavity via the tympanic canaliculus. Once inside the middle ear cavity, the tympanic nerve branches out to form the tympanic plexus on top of the promontory of the middle ear. These nerves then reunite toward the upper end of the plexus to form a single lesser petrosal nerve, as shown here. The lesser petrosal nerve exits the middle ear cavity via the lesser petrosal hiatus, and this nerve slides along the floor of the middle cranial fossa before exiting the cranial cavity via the foramen ovale. Here's another image illustrating these same parts of the pathway. Here again is the glossopharyngeal nerve, cranial nerve number 9, giving off the tympanic nerve, which forms the tympanic plexus on the promontory of the middle ear cavity, and those nerves, when they reunite, they form the lesser petrosal nerve, which exits via the lesser petrosal hiatus to slide along the floor of the middle cranial fossa. And eventually, the lesser petrosal nerve will exit here at the foramen ovale, along with V3, the mandibular division of the trigeminal nerve. Once the lesser petrosal nerve exits here at the foramen ovale, it very quickly synapses within the otic ganglion. So up to this point, all these nerves have carried preganglionic parasympathetic fibers. Now here within the otic ganglion, which is immediately adjacent to V3, the mandibular nerve, the synapse occurs, and from the otic ganglion, the postganglionic parasympathetic fibers are conveyed through the auriculotemporal nerve back to the parotid gland. Now let's finish up this pathway. Here again is the lesser petrosal nerve sliding along the floor of the middle cranial fossa to exit the cranial cavity via the foramen ovale, along with the mandibular nerve V3. Once the lesser petrosal nerve enters the infratemporal fossa, it quickly synapses within the otic ganglion. From here, the postganglionic parasympathetic fibers are conveyed through the auriculotemporal nerve down to the parotid gland in order to stimulate salivation. Do be certain you become very familiar with this pathway and all the nerves involved. And speaking of the auriculotemporal nerve, there is actually a syndrome associated with it called Frey's syndrome, or auriculotemporal syndrome. After a patient has had a parotidectomy, the auriculotemporal nerve will regenerate, and the fibers of this nerve can attach themselves to sweat glands in the skin of the cheek. When the patient eats, instead of the auriculotemporal nerve stimulating salivation on the side where the parotid gland was removed, it instead stimulates sweating. This actually makes perfect sense. As you might recall, acetylcholine is the neurotransmitter used by postganglionic parasympathetic fibers. In other words, acetylcholine is a neurotransmitter used by the auriculotemporal nerve to stimulate salivation in the parotid gland. However, acetylcholine is also the neurotransmitter used by the sympathetic nervous system to stimulate sweat glands. So instead of the released acetylcholine stimulating salivation, it is now stimulating sweat in the area where the parotid gland once was. This concludes the video on the face and parotid region. As always, happy studying!